Buenos días a todos y gracias de nuevo por estar aquí. Es un honor, es un placer tener de nuevo esta conferencia. Thank you all of you for being here in this conference. We are very pleased, we are very happy. It's an honor to have you all of you here. This is our fourth international conference under the grant U54, this infrastructure that has this collaborative agreement with MD Anderson Cancer Center and University of Puerto Rico. Repito, esta es nuestra cuarta conferencia internacional que la organizamos dentro de la infraestructura del grant U54, que es la colaboración con MD Anderson y la Universidad de Puerto Rico. La conferencia de este año le hemos titulado Research on Cancer Epidemiology, Risk Factors and Control in the Caribbean Basin. This is the title of this international conference. Before starting, I would like to ask one of the PIs of this grant to come to give us some welcome words. And initially, we invited Dr. Erick also to be here as part of the welcome words ceremony, but she's unable to come because she has, as you know, as most of us, has this problem of influenza, all the things that is happening actually, this public health problem that we are suffering in many places. Well, anyway, we have the opportunity then to invite Dr. Tortolero to give us the welcome words. So I will ask Dr. Tortolero to come to the podium, please, and please welcome Dr. Guillermo Tortolero.
Thank you. Thank you all. Good morning and welcome to Puerto Rico. For those who have been here for the first time and for those coming back, welcome back. It's a pleasure to have you here. As Erick mentioned, this is one of the activities that the Partnership for Excellence in Cancer Research between the University of Puerto Rico and MD Anderson has as part of their U54 grant. Dr. Erick Suárez and his team have been organizing this conference on an annual basis with a very international focus on topics that are related to our interest too, and identifying speakers all around the world, really, that are very good speakers, very much good match in terms of the work that we are trying to do here in Puerto Rico, and we really appreciate for some of you having to travel long distances to be here with us for this couple of days. Again, it is a pleasure to welcome you to Puerto Rico on behalf of the U54 partnership between University of Puerto Rico and MD Anderson, and we hope that you enjoyed the 2 days of the conference and that you find it productive, and that for those of you who are visiting, that you have a time to see around and visit a little bit of the island. Thank you again and welcome.
Well, thank you, Dr. Tortolero, and I think we are ready to start the conference. You have all of the programs, and we are going to start with Dr. Robert Hiatt. It's a great honor and pleasure to have you here, Robert. I know that you are coming back after a long time living in Puerto Rico. Robert Hiatt is a professor and chair of the Department of Epidemiology and Biostatistics at UCSF, it's University of California in San Francisco, and the Director of Population Science and Associate Director of the UCSF Comprehensive Cancer Center. He's also an adjunct professor, Division of Epidemiology, University of California, Berkeley, and adjunct investigator at the Division of Research, Kaiser Permanent Medical Care Program in Oakland. From 1998 to early 2003, he was the first deputy director of the Division of Cancer Control and Population Sciences at the National Cancer Institute, where he oversees cancer research in epidemiology and genetic surveillance and health service research. So he's an extensive experience in this area of public health and cancer. So we We are going to know more about Robert, so I just want to say the title of his conference is The Social Determinants of Cancer, a Challenge for Transdisciplinary Science. So please welcome Dr. Robert Hiatt.
So, buenos días. I used to speak a lot of Spanish, much better than I do now, so I thought maybe I would try, but then I'm chickening out. So I'm going to speak in English. This is a presentation that maybe is appropriate to begin the conference because it's very broad, thinking about the context of cancer and its determinants. What I want to do in the talk is cover two big ideas. One of them is that we should be thinking about the social determinants of cancer as well as the clinical care of cancer patients, the biologic underpinnings of the disease. And the second idea is that we want to approach this problem through transdisciplinary means. Now, I'm going to explain what that means, but basically it's a perspective that drives us to think about problems in science in general, but in cancer in particular today, from many different angles. I have found this type of approach to be very intellectually challenging and very interesting and productive. And if any of you haven't been introduced to it yet, I hope that my comments will be enlightening. So now I realize that the microphone works, but let's see if this works. Voila. So this is what we're going to talk about. I'm going to spend a little time talking about what I mean by some of these terms, in case some of you don't know. I want to give you some, let's call them conceptual frameworks that help you think about social determinants in the context of other problems and approaches you may have. I'm going to give you one example, spend some time talking about a project that I'm working on now in breast cancer, and then come back to how I've used this particular problem in breast cancer in a social determinant context. All throughout this, the theme is going to be working with multiple other disciplines, multiple colleagues from other perspectives to solve a common problem. So population health is the big context. I'm an epidemiologist. I'm concerned about population health. I'm concerned about where disease comes from, its distribution, and as opposed to public health, this term is becoming more and more common in usage in this field. And I want to define it to have several aspects of it. Let's see if this is a laser pointer. Good. So an approach to health that aims to improve the health of the entire population and reduce health inequities. So this is health disparities concerns among population groups. So in order to get there, we need to look at a broad range of factors and conditions that influence our health. So this includes income and education, environment and biology. It includes working with other parts of society, maybe engineers, lawyers, urban planners, to think about where health problems come from and try to resolve issues that are really social, that can actually influence cancer. The approach is transdisciplinary. What is transdisciplinary? Why make a new word? Why use this new term? A couple things are true about transdisciplinary health, transdisciplinary science. It draws from different disciplines, and it tries to generate novel conceptual and empirical analysis of a particular research topic. So you may be an oncologist, a infectious disease expert, an epidemiologist, a sociologist, a cell biologist. You have particular training in your discipline. You're very good at that particular discipline. But what transdisciplinary work does is encourage you to work with others to bring your skills to the table and try to learn something in between. So if you're an epidemiologist and you're working with a sociologist, what are the differences in the two disciplines that help you? If you're a molecular biologist and you're working with an oncologist, what are the ways that your knowledge can be used to improve the diagnosis and treatment of a cancer patient, et cetera? So it's different than other types of interdisciplinarity or multidisciplinarity. Multidisciplinarity means you just get a bunch of people who have different disciplines and you put them in the same room and they work on something, but they basically do it on their own. No interaction. It's a multidisciplinary team, but there's no interaction. Oops, sorry about that. Interdisciplinary is cooperation of different disciplines that fall between the disciplines. There's more interaction, but the thinking is still based on a person's background discipline. In transdisciplinary research, the collaborations are across the disciplines. They actually alter your disciplinary thinking. You learn from somebody who you're working with to think about a problem in a different way. And by integrating these different disciplines around a common scientific goal, you hopefully develop new models, new theories, change paradigms. This is the idea. So one takeaway message is that transdisciplinary science requires a common problem, common understanding of a conceptual model. So you have to have some way that everybody sits around at the table and understands what the problem is. So for us, the problem was cancer of the breast. And we have cellular biologists, geneticists, epidemiologists, nutritionists, modelers. Everybody had to worry about the etiology of breast cancer. And what were the different perspectives and how did we do that? One thing that happens when you do this is you realize that you're working both on biology, all the omics, the genome, the transcriptome, and so forth, but you're concerned, and I'm sorry about the slide, about influences from outside. So policy and neighborhoods, workplace, exercise, smoking, diet. How do these things get so-called under the skin and interact with biology to cause disease? So some of you may be studying tobacco. Some others may be studying genetics. How do these things interact to cause cancer? One of the organizing principles that we used at the NCI that has stood the test of time is the cancer continuum. So many of you are familiar with this. We developed this with David Abrams back in the late 90s at the National Cancer Institute to think about cancer control across the continuum. And that takes us from prevention to detection to diagnosis, treatment, and survivorship. And in each area, you find conditions which lend themselves to thinking in this way across disciplines. And then, of course, there are many sort of cross-cutting issues that have to do with genetics as well as the social determinants and other issues. So this had led me with Nancy Breen to develop a model or a conceptual framework that we called the social determinants of cancer and published on in 2007. So here's this cancer continuum here, from pre-disease to preclinical to incidence and so forth. And at each place along the continuum, you have opportunities for interventions. So here your interventions are prevention. You're trying to prevent, say, smoking. Here, your early detection. So you're studying HPV and Pap smears. Here's treatment. So you're coming up with new ways of treating disease. And then after diagnosis and treatment, you're concerned about quality of life issues, for example. So these are interventions. This is the continuum. And at each point along the cancer continuum, you have multiple levels of influence. Now, I've just selected 4 here, but you could think of others. There's a biologic aspect to each one of these. Behavior, such as smoking or diet or exposure to the sun, is influencing the biology. The healthcare system comes in here someplace. We would hope in a full healthcare system that you're influencing these factors all along the way, but basically it's just before diagnosis and afterwards where health system issues come into play. And social determinants, I argue, are also important all along the way. The healthcare system doesn't influence pre-disease so much. So if you're looking at cancer incidence, you're basically looking at the influence of social factors, behavior, and biology. This is a framework which I've found very useful in thinking about cancer problems and incorporating social determinants in the picture. One argument I make is that if you're interested in these questions at the social level, they need to be integrated. It isn't something separate, where you're only thinking about the influence of, say, crowding or neighborhoods. There isn't a direct relationship between where you live and whether or not you have cancer, but there's an indirect relationship, and you have to understand what the steps are between. So it's an integrated approach to problem solving. This is one example of a so-called social ecologic model, where you have to think about problems at different levels. So in this case, you have genes, cells, tissues, individuals. Usually it stops here. Usually most of the research we do is in this area when we try to understand cancer. But when you really think about it, how can we say that the family organizational unit, the neighborhood that you live in, our society, doesn't have an influence on our health? We all know intuitively that it does, and we have evidence for it multiple places. What I'm saying is that these things need to be integrated in our thinking. And you can think easily about different places along the continuum where this is true. So in prevention, we're thinking about tobacco use, and that is influenced by culture, by who you're around, by the influence of your friends, by tobacco company advertising. These are all social factors that are driving behavior, that are driving cancer. Early detection. Who gets Pap smears, who gets mammography, is determined by, again, behavior, by your family, by your friends, by whether you have enough money, by whether you have access to high quality care. These are social factors. Diagnosis can be informed by education, income, and who gets treated in certain ways are influenced by the setting in which the treatment is offered. And treatment itself is influenced by, now more than ever, patient-centered concerns. So now we have PCORI, right? The Patient-Centered Outcomes Research Institute, which is focused on what people, on metrics that influence how people think and what they want in terms of treatment. These things in turn are heavily influenced by their social situation. And survivorship and coping strategies, again, are influenced by culture, where you come from, and so forth. So these are all examples of social determinants influencing cancer in some way. Now I want to give you an example. So this is a study that I'm involved in currently. And it's called the Bay Area Breast Cancer and the Environment Research Center. It's funded by the National Cancer Institute and the National Institute of Environmental Health Sciences. So breast cancer. All of you probably know this, but it's the most common cancer in women. And it's generated excellent treatment in many cases, so that now we have over 3 million survivors. Still the most common cancer in women in our part of the world and in most parts of the world. There are a number of established risk factors. Many of them have to do with reproductive and hormonal factors. Agent menarche is the one I want to focus on here. If a girl goes through menarche over age 15 versus one that goes through menarche under 12, she has a highly significant protective relative risk for breast cancer in adult life. And you're familiar with the influence of age at first birth, parity, education, benign breast disease, maternal health, and sister history. But this finding of age of menarche is robust. It's been found all around the world. It's consistent over time. And the sort of dominant theory is that the earlier a woman goes through menarche, the longer period of time she's exposed to estrogen, cyclic estrogen, and that's the source of the risk. So how did we find that out? Well, it's through the usual epidemiologic approach. You take adult women, you establish a case control study or a cohort study, and you try to understand it from that perspective. So you're asking adult women when they had their first period. And as with most case control studies, you have problems with recall bias and accuracy. Prospective studies, of course, are the best, but they're very lengthy and expensive. And you have to go through not just one study, but multiple ones to get replication and validation. And use things like meta-analysis or systematic reviews to put together the information. That's what we usually do. But there's another way of thinking about cancer and many other diseases, and that's to think about it over the life course. And what does that mean? Well, there is increasing evidence that there's influences on breast cancer etiology that start way early. So in utero experiences, birth weight and exposures, maybe even stem cells are thought to be related to breast cancer etiology. During infancy, feeding patterns which lead to obesity, how fast the girl grows, what's the age of menarche, first birth, menopausal transition. So if you just think about it for a second, you can see that the influence on breast cancer is really a life course perspective. Life course perspective. So why don't we focus on earlier ages of development to better understand what might be leading to breast cancer. So it's an established risk factor, that is age of menarche. Puberty is also interesting, isn't it? Because it's a time of rapid breast development. It's the only organ in the human being which actually develops after birth. So here we have an opportunity to understand cellular growth and development of the mammary gland during puberty as a precursor to breast cancer. And some of you may not be aware, but the age for the initiation of puberty is likely due to environmental factors for reasons that I'll show you. So if you look around the world, usually the understanding is that puberty occurs earlier in well-off populations. So here's a good example for Venezuela. So well-off Venezuelan girls go through puberty, or this is menarche, at age 12.3. And you can't see it here, but this is 12.9 for less well-off girls just in Venezuela. And you can see the same thing in Africa or the Cameroon. And you see in underdeveloped countries like the Senegal that the age at menarche is 16. And the general message here is that as the world has changed, become more industrialized, the age at menarche has decreased with development. And here's a better way to look at it. So these are European countries that have kept data for a long time. This number over here is 1830. So in Norway, they're keeping birth records and developmental records on their population from way back during the time before our Civil War. So these are all European countries except for the United States. And you can see that the age of menarche, again, menarche, has dropped from age 17 to age 13, 4 years over a period of about 120 years. That's been known. This is Korea. Just since the 1920s, over a period of 50 years, not 120, the drop in the age has gone from 17 to 13. Something about development in the country of Korea has been associated with this rapid change in a very basic sort of reproductive risk factor. And during this time, there's been an increase in breast cancer incidence in the world. A very famous study in this area was done by a pediatrician named Marcia Herman Giddens and published in 1997. And there she looked at a bunch of girls, white and African American girls, and documented that the age at menses was actually younger. It was starting even at age 10 and 11 in the population she studied, and that there was a large difference between African American and white girls. So there was race ethnic differences coming up here between at least these two groups, where African American girls were starting earlier than white girls. And if you looked at breast development, which occurs before the first period, and you measure it by this thing called the Tanner stage. Tanner was a pediatrician who standardized the estimate of breast cancer. You can see that girls were starting to develop breasts at age 7, 8, 9, and so forth, again, more rapidly among African American girls. And pubic hair is the other secondary sexual characteristic characteristic of pubertal development. They're the same sort of picture. So what we've known going into this study about a decade ago was that there was a downward age onset of puberty over the last century. There were decreasing trends in the age of menarche, which were not parallel to puberty. So that what I mean by that is that the age of menarche had decreased over the last 100 years, but then stabilized. And the age at puberty now has decreased. So that the distance in time between puberty and menarche is not stable. It changes. It's not tied to each other tightly. And during this time, there's been a rapid change in the relationship of socioeconomic status with pubertal onset. So what do we do? So, well, let me make sure my time is good. How much time do I have, Eric?
15 minutes.
15 minutes, okay. So speed it up. So, so here's the center we have. It's called, as I said, the Breast Cancer and Environment Research Center. It started in 2003. We included both animal models of breast development and an epidemiologic study. This was done at Kaiser and UC. And it had cores in outreach for the community and an administrative core. We had a common problem. We were interested in what drives the onset of puberty and how might the period of puberty be actually a window of susceptibility for breast cancer. What might be going on during this period that we needed to learn about. So, as I say, we included animal models. Animal models allow you to actually look at the breast tissue as it's developing. And gives you a life course approach. And some of the new techniques in cell biology and anatomy allow you to use fluorescent stains. So in vivo models, you can actually see the growth of breast ductals and terminal end buds and understand the influence of various environmental factors on them. Very, very helpful models in terms of looking at the whole life course. But the thing that I was involved in more thoroughly was the epidemiologic cohort, being an epidemiologist. And what we wanted to do there was to look at a number of different exposures and their effects on the onset of puberty. So our outcomes weren't breast cancer, they were Tanner stage, breast development and pubic hair development, and the tempo, which is the difference between the two. I'll show you that. And I'll show you some of the things we tried to collect. So this was a cohort study. We recruited girls who were about 7 years old from this health plan. So we knew they were born in the health plan. We knew about their growth up to the time that they were recruited. We had their birth records. So we called it the Signet study because we had a previous study called the Swan study. And so the Signet study was the young girls. And we had to make up a name that would fit Signet. So this is a sort of a tortured name. Cohort study of young girls' nutrition, environment, and transitions. But basically it allowed us to call it the Signet study. And it took place in Northern California. This is the Kaiser Permanente Health Plan hospitals around the Bay Area. This is San Francisco here. This is Richmond and Marin. And this is Alameda and Contra Costa, the counties around there. And this is our study population. It's a very multi-ethnic population in California. So if you just look at the totals over here, about 26% were Asian or Pacific Islander, about 18 or 19% Black, 19% Hispanic, and so forth and so on. And these were our outcomes. We were interested in breast development, in menarche, in the growth and obesity, pubic hair development, in this thing called tempo. And we were interested in these outcomes, but also there's all sorts of things that happen during adolescence which were important to us because of what happens with earlier development. And we wanted to be able to study early sexual activity, pregnancy, depression, and so forth, as well as the influence on breast cancer. So here's the tempo story. So you can have the onset of puberty at the same age for these are 3 different girls. So you could have the onset of puberty at age 10, but one girl may develop her first period at 12, another at 13. So you see the tempo is different. So that's another outcome. So what were the things we were looking for? Well, food intake, physical activity, cigarette smoking, endocrine disrupting chemicals. We were measuring fat through impedance analysis and annual examinations, Tanner staging, which is the standardized way of looking at breast development and pubic hair development. We were interested in multiple environmental exposures, cigarette exposure and so forth, medical history, psychosocial measures at the social level, family stress, family structure, demographics, dietary intake, physical activity, very difficult, as many of you know, to gather. Nevertheless, we spent a lot of time understanding the activity patterns of these young girls, how much time they spent in front of the television, for instance. And we gave them pedometers. Now, this is actually, just as a sidelight, we thought that they would lose the pedometers and that it wasn't going to work very well, but it worked great. They all were very proud to bring in their pedometers and show us the results. Just a little tip in case you want to do that yourself. And then, of course, we did these measurements in great detail of their development. We collected urine, blood, and saliva. We were very interested in the social factors, social economic status, family structure, depression in the mother, and absent fathers. I'll tell you what that means in a minute. So this is just 2 slides to show you our early results. If you look at the total column, you can see that the onset, and this is age 7. So these are African American, Latino, Asian, white girls. And you can see that even at age 7, 29% of the African American girls had developed breast budding, age 7. 15% of the Hispanic girls and so forth. big differences between race ethnic groups and earlier development than even the Herman Giddens study. Then 8 years, a year later, 43% of the black girls, 31% of the Hispanics, 18% of the whites. So we are observing even earlier development of early pubertal signs in these girls than was observed 10 years before. And then we're getting other interesting results that have to do, we think, with sort of higher level upstream factors. So it turns out that in girls whose biologic father is not in the household, father absent, they develop breast cancer, develop puberty earlier. This is something that has been observed in animal populations as well. That is, in social animals, if you take the biologic father out of the mouse colony, the pups will go through estrus earlier. It's a very well-preserved evolutionary fact, it seems, that the biologic father, for some reason, presence delays the onset of puberty. So we're seeing this in these girls, among the higher income girls, not the lower income girls for some reason, but we were able to document this pathway in our girls as well. Then we looked at socioeconomic status and onset of B2. So as I've told you, higher SES is consistently associated with cancer incidence around the world. And the conventional explanation is that higher socioeconomic status is associated with reproductive patterns that lead to higher exposure to estrogen. And that's what the common knowledge is. So our questions were, what's the relationship between SES and pubertal onset? What's the mediators and moderators of that relationship? And in particular, what's the role of body mass index, race, ethnicity, and geographic location? And we were able to show that, at least by measuring it by income, that there was an effect of income on the onset of puberty. Ratio of medians gives you a statistic like this, which essentially is equivalent to about 3 months of time. So that these girls were going through puberty almost 3 or 4 months earlier than girls who were from families that made over $100,000. And then when we looked at it through various models, just to be quick about it, the model, it was maintained if you controlled for BMI, maintained if you, these are, everything in red is statistically significantly earlier, maintained if you look at different race and ethnic groups, different sites where we did the recruitment, if you included BMI and race and ethnicity and so forth. And it wasn't until you threw everything into the model that it became no longer statistically significant. But the point is that there's something about socioeconomic status is driving earlier development that is not related to BMI. I mean, it's only partially related to obesity. So what we had thought going into the study was that there's been a shift in what happens with socioeconomic status and the relationship to puberty, at least, is one factor in breast cancer risk. And that's because girls and boys are becoming more obese these days. And that's, we thought, that was our theory, that was the reason for that direction. But it turns out not to be true. And so Erick's telling me I'm almost done. So I'm almost done. So this is our DAG. Our tentative conclusions were that it was related and not related through BMI. So our social determinants in this study have to do with race and ethnicity, socioeconomic status, geographic location, and so forth. All of these things we had to take into account in a transdisciplinary way to make sense of our findings. And what we did was think about this social ecologic model across all phases of development, from prenatal to post-menopausal years in our mouse models, and focused on puberty in the epidemiologic study. And we were able to think about different hypotheses at the social ecologic level over the life course. So here's a case where early childhood exposure to endocrine disruptors related to hormonal development and earlier puberty, and theoretically to the development of breast cancer later in life. It was a way of thinking about different hypotheses through this transdisciplinary approach. But we had other models, which I'll just conclude with. So many of you maybe who are interested in modeling know about complex systems models and ways of thinking about complex systems. The Foresight study in the UK looked at obesity and nutrition and came up with what's called a spaghetti plot. So you can't see this, of course, but what I'm trying to show you is ways of thinking about relationships across different areas. So we did this for breast cancer. And we pulled together a team. The names aren't important, but it's a multi-ethnic, multidisciplinary, transdisciplinary approach with these types of people. We had social epidemiologists and medical oncologists and geneticists and so forth. And we asked them all to think about the etiology of breast cancer. And this is what we came up with. So in this model, which looks at social cultural factors like education, race, ethnicity, behavioral factors like physical activity and hormone replacement therapy, biologic factors like genes and breast density and height, and environmental factors like sleep and endocrine disruptors, all looking at postmenopausal breast cancer. Each one of these arrows has literature behind it and relative risks to document it. So we can manipulate this model and see what the effect on postmenopausal breast cancer is with manipulation of its individual pieces. And then there's other models out there. You maybe know the Christakis-Fowler models where you're looking at social networks. Again, social factors influencing obesity, tobacco use, even though people are not in close proximity. And I'll conclude by just saying, what's the point of all this? Because as you might think, when you work with multiple different disciplines, you run into some problems. And in fact, you have more hassles just generally with communication, different institutional and disciplinary cultures to deal with, multiple IRBs, so forth and so on. But I would say that this type of collaborative multi-center approach can accomplish things you can't do by yourself. You can use expertise that may not be in your own pocket. You can learn from one another, be more productive, and I think it's fun. So I thank you very much.
Now we have our second speaker, and it's also an honor to have Guillermo Tortolero, Dr. Guillermo Tortolero, a friend of us and colleagues from the University of Puerto Rico, and also is a member of the Comprehensive Cancer Center. You see his photo here. He's quite young. That was 20 years ago.
No, like a 10. That's for Puerto Rico, that's 2 years.
Dr. Tortolero is the director of Cancer Control and Population Science program at the University of Puerto Rico Comprehensive Cancer Center. Dr. Tortolero research interests primarily in primary and secondary prevention of gynecology cancers. And his interest has been on the epidemiology, carcinogenesis, diagnosis, and management of this neoplasm. In addition, he's interested in the study of pap smear usage and mammograph screening and the predictors, and of this behavior among low-income Hispanic women. And he has been here in Puerto Rico for the last 6 years, and he has been very productive here in his work, working with the different agents, local agency, government agency. And previously, he was faculty of the Department of Gynecology Oncology at the University of Texas in MD Anderson Cancer Center. But then, as I told you, 6 years ago, he moved to Puerto Rico. So his talk now in this conference will be, is titled the Case Prevention and Control Intervention in Puerto Rico. So please welcome Dr. Tortolero.
Hello, can you hear me well? Well, thank you, Eric, for that introduction. I think that the description of my interest is as well as the picture. But things have been changing, and since I'm here especially, I have to broaden a little bit more what I was doing before coming here. The idea is to give you a little bit of information about what is the burden of cancer and what type of activities are we doing as a program at the Cancer Center, as a cancer control program, in collaboration with too many other agencies and individuals, organizations in Puerto Rico in trying to develop a strategy, some implementing strategies for cancer control. Our mission at the program, at the Cancer Control Program and Population Sciences at the Cancer Center is to develop a multidisciplinary program, transdisciplinary program, I will say these days. In this slide, it was a little bit old. We only had, when I moved here, the idea of developing a research program, but now we have other aspects that we are covering. But the main focus of this is on cancer health disparities, and our main goal is to reduce the burden of cancer in Puerto Rico through collaborations, education, research, and implementation of evidence-based. Our mission, our vision is to become a very well-recognized program and be able to have some activities, some relationship with our neighbors in the Caribbean and Central America and South America in order to move these agendas. This is just to show you how we are organized right now at the Cancer Center, Population Sciences, Cancer Control and Population Sciences Program. We have the support of a biostatistics and informatics core that is being led by Dr. Perici at the Rios campus, at the Rio Piedras campus of the University of Puerto Rico. We have been in the process of developing a repository that eventually will be another core for support of the activities that we do. We have a very small team in terms of faculty, in terms of researchers, but a very active program, a very active research group in the area, particularly of epidemiology related to HPV and other aspects of women's health, like breast cancer, endometrial cancer, with some particular interest on obesity and metabolic syndrome. There are some other areas in HPV in men that has also been explored, and some aspects on behavioral sciences that have been developed, particularly in collaboration with the U54 partnership between MD Anderson and the University of Puerto Rico. And some few steps in health services research that have been led primarily by the group at the Cancer Center, at the Cancer Registry, but Dr. Naida Figueroa, Dr. Ortiz, and Karen Ortiz at the Cancer Registry. We also have the fortune of having the funding from the CDC for the prevention and cancer control programs, and we have, through a memorandum of understanding with the Department of Health, we are the bona fide agents for these three programs: the Puerto Rico Comprehensive Cancer Control Program, the Puerto Rico Breast and Cervical Cancer Early Detection Program, and the Cancer Registry, Central Cancer Registry. These programs are under an umbrella since last year, or this fiscal year, that is named the Cancer Prevention and Control Coordinating Center. Basically, it's an umbrella that from the administrative point of view, and activities are trying to work in a more integrated way. We have a different situation. The three programs are under the same building, and we have been able to have a very good communication even before this new organization that we started last year. Certainly, having the Comprehensive Cancer Control Program and the Breast and Cervical Cancer Early Detection Program allow us the opportunity to provide outreach education to the population and providers, and also provide access to screening services to those populations in need, particularly those without health insurance in Puerto Rico. And the Cancer Center, the Cancer Registry allow us to do our activities of surveillance, and also provides data for us to measure our impact, our progress in terms of the interventions that are being implemented. There are other sources of data and other collaboration that also help in this effort of measuring what's happening in terms of our efforts. I'm just going to go briefly over this, just to give you an idea of what the situation of cancer is. Probably you will see other presentations later on that also present some data. So I'm going to go a little bit fast over this to try to cover most of what we have to cover. Cancer is a major problem in Puerto Rico, like it is in the rest of the US and in the world. It's the second leading cause of death in Puerto Rico. It accounts for approximately 25% of all deaths in Puerto Rico. And in 2009, there was an estimated almost 13,000 new cases of cancer that were diagnosed in the island, and about 5,000 individuals died from cancer during 2008. This is the distribution of cancers by male and female in Puerto Rico for the period 2005 and 2009. And this is all data generated by the Cancer Registry here in Puerto Rico. The number one cancer in men is prostate cancer, followed by colon cancer and lung cancer. We have a slightly higher or substantially higher proportion of cancer, prostate cancers in relation to the total number of cancers that are diagnosed. But certainly you can see that prostate, colorectal, lung cancer, and oral cavity cancers are among the most important cancers in men. In the case of women, breast cancer, like in the US, is the most common cancer, followed by rectal cancer, by colorectal cancer. And in the last years, thyroid cancer moved from the 4th to the 3rd place. And that's something that we have been looking at and paying attention, trying to understand what is happening in Puerto Rico and if this increase is different than what we have been observing in other populations. Cervical cancer is about the 6th, and lung cancer is number 4. Another interest for us, uterine cancer, is number 4 in Puerto Rico. In terms of mortality, we have more or less the same situation. Prostate, lung, and colorectal are the number 3 cancers in men, and breast, colorectal, and lung in women. And as you can see, that provides some opportunities for some impact in terms of cancer prevention and control, given that prostate, colorectal, and breast are probably about 50% or substantial amount of the proportion of cases that we see related with mortality. This is a graph that shows you what is the trend in cancer overall in Puerto Rico in terms of incidence between 1987 and 2009. The blue line is for men, the red line is for women. And as you can see, from 1987 to 2009, there has been an increase in cancer in both men and women. Men has a higher rate of cancer than compared with women. And in men, we seem to be observing a decrease in incidence in the last 4 or 5 years that we need to continue observing to see how it's going to behave. And in women, seems to be stabilizing, at least for now, that rate. But in the last 15, 20 years, we have been seeing an increase in incidence, as well as in both in men and women. Also, like in many other countries, we see that cancer in Puerto Rico is related with age. The incidence of cancer increases with age, particularly after age 50, 55, we see a dramatic increase. And also we observe that the difference between men and women is maintained over the different age groups. But also we see that this difference between men and women increases with age, probably related with the high number of prostate cancer diagnoses that we have been observing in Puerto Rico. I'm going to go over, this is just an example of the different data that can be produced by the Cancer Registry. We can look at the trends of the data by different sites. And I'm going to go fast over this just because I don't want to, I thought that I was supposed to talk more about this part. But also we look at the data in the Cancer Center by geographic region, and they develop a socioeconomic index that has been used in several publications that also allow us to identify several groups of population that might be a particular risk for particular cancers. So this is a very important tool for us, as I mentioned, in order to make decisions about where we are, try to identify priorities, and try to measure the impact that we are having. In addition to to the burden of cancer in Puerto Rico, we also have a profile of risk factors that we need to pay attention in order to make decisions about what is important to intervene. As we know that in Puerto Rico, the population has been shrinking. If you see the two graphs here, this is the population distribution in 2000, and this is the population distribution in 2010. You can see a difference in the shape of the figures when we see that we are increasing in terms of older population and decreasing in the number of younger individuals in Puerto Rico. There has been a decline in the population growth in Puerto Rico that has been observed in the last decade that seems to continue until now. And as you can see, from now 2002, 2003, the population in Puerto Rico has been declining annually in a very interesting, dramatic way. And in 2010, for the first time, there were more Puerto Ricans living outside Puerto Rico than in the island. And the population estimates in 2010 went down from 3.9 to 3.7. So we are losing population in Puerto Rico. And this is just a graph to show you what had been the trend of this population in Puerto Rico. From 1992 to 2012, we went to a peak in the last decade, and from then there was a decline. We see that the number of individuals, the reason because we are decreasing in population is because there had been a migration from the Puerto Rico to the United States. There is a lot of activity and a lot of towns in the United States that are growing in terms of the number of Puerto Ricans. Orlando is a case, for example, where the population of Puerto Ricans has increased substantially in the last years. But seems to be like in the last few years, we had been a stabilization or a decline in that migration pattern. The bad news is that who is migrating and might have an impact on our risk of cancer too. The population that is migrating is population that is particularly younger. The green light is the population by age group that has been migrated in terms of percentage. And the population in blue, or the line in blue, is the population in Puerto Rico. As you can see, there is a larger number of younger population who is migrating to the United States, what might explain why the population is not only decreasing, but also changing the shape in terms of the population over 65 years and older. Also, the population that is migrating is not the less educated, but it's the one with a little bit more educated and more education. Here in the green bars, you can see the population that is migrated. In the blue, purple bars, the population in Puerto Rico. And the larger impact, even among the educated, seems to be in those who have graduate degrees. And so we are not losing only population, we are using young population, we are using a highly educated population, and we are using, because of the background in terms of education, we are using a population with a higher potential for income. This is, in terms of education, we can see here too, the population that is migrating in higher proportions are population that is in this area that has higher level of education, and this was particularly seen in the last decade, as you can see in the second part of the last decade. As mentioned before too, the population that is migrated also has a higher income compared with the population that is returning to Puerto Rico and compared with the population that is living continuously in Puerto Rico. So in terms of what is the demographic characteristics in Puerto Rico right now that also are some risk factors for our incidence for the burden of cancer in Puerto Rico. Puerto Rico, as we mentioned, is a population that is getting older, and the younger people is moving fast out of the island, so the problem of age might be increasing over time. When we compare the median age of Puerto Rico, it's 36. For Hispanics in the U.S., it's 27, and Puerto Ricans in the U.S. is 28. And in general, for the U.S., it's 37. So we are an older population in terms of the Hispanic groups. In terms of income, the population of Puerto Rico has a median annual income below the different groups, below the U.S. and below Hispanics and Puerto Ricans living in the U.S. In terms of poverty level, our poverty level is about 44% of the population, compared with 14% in the United States. 24% of Puerto Ricans in the U.S. live below poverty level, and Hispanics are about 23%. So we have a substantial, almost 2 times a higher proportion of population below poverty level. We have a good situation in terms of education. But, we have a larger proportion of individuals with bachelor's degree compared with Hispanics in the U.S. and the U.S. Overall. But as we mentioned, we have to somehow find a way to stop the immigration of those individuals who have higher education in that. And there are some particular sections of the population that is educated who is migrated in certain sectors of the economy. And also, an advantage for us is that the coverage of health insurance is high in Puerto Rico. There are only an estimated 8% of the population who doesn't have health insurance. As you know, in Puerto Rico, we have a state health reform that covers about 40% of the population. The rest of the population is covered by private insurance, and there is a small proportion, 5 to 8% of the population that don't have any type of insurance. In addition to these characteristics, demographic characteristics that might impact the risk of cancer, we also have some risk factors that might increase our risk for certain type of cancers. For example, diabetes is higher than in the United States. The median in the US is 8.7% of those responding to the BRFSS in 2006 reporting to be diabetic, while in the Puerto Rico, this rate is almost 13%. Overweight, we are very similar to the US. It's an important problem in Puerto Rico. Overweight and obesity also contribute to some risk factors, as a risk factor for some of the cancers that we are interested in and that affect the population of Puerto Rico. Physical activity, we are below the median in the US. Another factor that impacts some of the cancer relates very much with obesity and with diabetes too. And fruit and vegetables consumption, we are also below the median in the US. So we are aspects that we need to consider in terms of our planning. There has been some progress in these risk factors from 96 to 2010 as measured by the BRFSS. And we made some, we increased the diabetes rate in Puerto Rico, and that's a negative impact. But for overweight, also went up. For physical activity, we gained a little bit in terms of the proportion of women, of individuals reporting having some type of physical activity last month. And in the consumption of fruit and vegetables, there was basically no change from what we have seen from previous years, very similar from 20 to 18. Other factors, other characteristics of the behaviors that we need to pay attention and that we have ability to measure periodically through the BRFSS is the screening behaviors. In Puerto Rico, in 2010, there was a lower rate of pap smear compared with the rate reported by the median in the US, 81% versus 75%. For mammography, we were more or less similar to the United States, independent if we look at 40 years and older or 50 years and older. But for colonoscopy, we need to increase our efforts to bring that rate of screening colonoscopy to at least the level of the US, where also is considered to be low, and a lot of efforts are being done right now to increase this screening rate. FOBT, that as in many other areas had been decreasing over time. In Puerto Rico, it's very hard to get FOBT. The major recommendation in Puerto Rico has been colonoscopy in the last years. And PSA, one of the screenings that we would like to have at least similar to the US but not higher, is higher in Puerto Rico. It could be in some way one of the explanations if we are doing more screening in Puerto Rico, might be one of the reasons because we are detecting more prostate cancers too than what, as we show in the previous slides, among other factors. This is just to show you the trend in those behaviors in terms of the screening behaviors in Puerto Rico between 96 and 2010. And we have increased in each one of these, except for FOBT and PSA. But we have increased in the proportion of pap smear done, the women reporting to have had a pap smear within the last 3 years. For women reporting having had a mammography 4 years and over, having had a mammography in the last year, as well as those 50 years and over. And colonoscopy went from 28% in 96 to 43%. So we are making progress, but still we have a long way to go. As I mentioned, the Cancer Registry has been doing the exercise of trying to estimate the cost of cancer in Puerto Rico. This was some estimates conducted by the staff of Dr. Figueroa, the group of the Cancer Registry, in 2008, and that is included in the Comprehensive Cancer Control Plan for Puerto Rico. And the estimation of the cost of cancer back in 2002, 2006, and these are preliminary estimates at that point, was 1.2 billion in terms of total cost. Of those, almost 400 million were related to direct medical cost, and about 800 million were related to indirect cost. So, as I mentioned, we in Puerto Rico have the opportunity to have the Comprehensive Cancer Control Program from CDC, and we have been using this program as our anchor to be able to develop these collaborations and to be able to implement activities in order to decrease or to prevent cancer in Puerto Rico. For those who are not familiar with the Comprehensive Cancer Control Program, this is a program from CDC, and the definition of a Comprehensive Cancer Control Program is a collaborative process through which a community pools resources to reduce the burden of cancer by working to achieve risk reduction, early detection, improved treatment, and enhanced survivorship. The Center for Disease Control defines this as the collaborative process through which community and partners pool resources to reduce the burden of cancer. The program started in '98, and in 2000 there were 10 states that have a cancer plan. By the present, all the states, tribes, and territories have a program in place. And the program provides some seed money, some small amounts of money that allow us as a program to establish a coalition, to do assessment of the burden of cancer, to determine priorities, and to develop and implement cancer plans. This is a map that shows where we are in terms of the United States, in terms of the CDC program, the National Comprehensive Cancer Control Program. As you see, all the states except for this tribe that was in planning stage back in 2008, 2009, the rest of the country we're in the implementation phase of these cancer plans. The CDC program works under this framework, from planning to implementation to evaluation, and we go to square one and start planning and implementing an evaluation. This is a non-ending story, and hopefully we will be making progress and changing every time that we make a plan. Those objectives will be more different in some cases, but also showing that we are making progress in the direction that we want to get. The concept of CDC works, as Robert mentioned, across the cancer control continuum, from prevention to survivorship, and we try to identify opportunities at all these levels to conduct interventions. What is the purpose of the benefits of having these programs? We try to reduce duplication of efforts, and by that reason, we have been making partnerships with all the key players in Puerto Rico that have interest or are doing work on cancer control to maximize the resources, enable changes in systems and policies, enables multi-level simultaneous interventions in some cases, and maximizes the impact on reducing incidence and mortality and improving quality of life. By this, we are able to get better outcomes by using evidence-based interventions, identifying where the gaps are, identifying priority issues, better allocation of limited resources, a focus on big picture in Puerto Rico, and a collaborative approach to create synergy. As I mentioned, we are part of we are bona fide agent for the Department of Health, and we are able to apply for the grant, administer the plan, and be responsible for the implementation of the cancer control plan. This is the structure that we have as I mentioned, of the Coordinating Center for Cancer Prevention and Control Programs, and the three programs are aligned, and we try to coordinate the activities that we conduct under these three programs. The Cancer Control Coalition in Puerto Rico was put like in any other states as a group of stakeholders, and this group of stakeholders are responsible for what I mentioned before, assessing the cancer status in Puerto Rico, identifying priorities for interventions and for us to act, establishing goals to reduce cancer burden, and identifying evidence-based strategies to reach these goals. This is just an idea, a representation of who is part of the Cancer Control Coalition in Puerto Rico. We have a representation of the State Health Department. We are bona fide agent, and we have a good representation of the different components of the health department. We have government agencies. We have individuals that, from the community that participate in this organization. We have professional associations and organizations that participate in the meetings and different activities. We have the private sector, particularly the insurance companies and the pharmaceutical companies have been key players in our efforts. We have community-based organizations. We have non-profit organizations. Our main partners are the American Cancer Society in Puerto Rico and the Susan G. Komen for the Cure, among others. We have the participation of the academic and medical institutions, the School of Medicine in Ponce, the University of Puerto Rico, and the different components that form part of this coalition. And we have the public health programs from the Department of Health to being an important player. These are the Central Cancer Registry and the Puerto Rico Behavioral Risk Factor Surveillance System, who provides a lot of the information that we need to develop these plans to measure our impact, and they are an important part of this component of this structure. Also, on the right side, you have 3 of the programs that we have been interacting more closely in order to reach our goals. The Puerto Rico Chronic Disease Prevention and Control, Prevention and Health Promotion Plan for Puerto Rico that has a very similar goals and objectives that we have. We have similar areas of interest, and we are working together to reach our goals. We work together with the Tobacco Control Program also in order to reach our goals of reducing the risk of exposure to tobacco and reducing the burden of cancer. And we work closely also with the Puerto Rico Healthy People 2020 in order to be able to align our goals and objectives and look for similar goals. This is the structure of the Comprehensive Cancer Control Coalition right now. The Comprehensive Cancer Control Coalition has a chair, co-chair, and the coalition, as I mentioned before, was responsible for identifying the areas of interest or priorities for Puerto Rico, and 5 groups were selected as priority areas: nutrition and physical activity, HPV and cervical cancer, breast cancer, colorectal cancer, and survivorship. We have been doing activities along in these 3 areas related with education of the population, education of medical healthcare providers, providing educational materials, etc., that I'm going to show you briefly in a second. So the coalition, again, meets periodically, makes decisions, and makes the decision based on the areas that we can impact more the population at a lower cost. As if you're familiarized with the health impact pyramid, given the situation that we have, the economical situation, we are trying to look at areas where the impact can be bigger and at a lower cost, and trying to reduce our interventions that require more face-to-face or personal encounters or individual encounters to be able to make progress. But certainly we are working across the pyramid, but trying to concentrate in areas where our impact can be higher. This is the Comprehensive Cancer Control Plan that has been our guide for the last 5 years. We are in the process of reviewing the plan this year for 2013-2017. And we invite all of you who live in Puerto Rico to be part of the coalition to participate in this effort. The cancer control has several areas: it goes prevention, screening, early detection, treatment, access, survivorship, training and research, and surveillance. And we will see how shape it takes for the next time, for the next generation. All these efforts, as I mentioned, have been informed by the research that is conducted in our group and by other groups in the island to be able to understand better the profile of cancer and the burden of cancer, and to try to identify areas of that can benefit more of our efforts. In terms of education, we are working in educational activities for the public, participating in different forums to be able to bring the message of early detection, prevention, and other aspects of interest for the population. Also, we work very closely with different health professional organizations to be able to conduct educational activities. We work with the insurance companies, with the pharmaceutical companies to be able to organize educational activities for professionals, and particularly in issues of and focus primarily for primary providers and aspects like where are the screening guidelines, what are the burden of cancer in Puerto Rico, what are the different areas of research that we are exploring, what are the situation in terms of vaccination in Puerto Rico, different information that might help them support our goals, but also help them to make decisions. For example, recently with the changes in the screening guidelines for cervical cancer, we have been trying to get the message to all primary providers and organizing activities that will allow us to make sure that everybody has the most recent information and is doing what it's supposed to be doing from last year into the future until the next review of the guidelines. Also, in terms of the, for example, in terms of the survivorship group, we are organizing a conference in April for primary health providers in terms of the in palliative care issues, because as I mentioned, survivorship is one of our areas of interest. We are collecting information among survivors, trying to understand what the needs of survivors are, implementing programs like the Live Strong programs for community involvement, and we are trying to work with this group because the needs are important for this population. We have been active with other groups and as part of the coalition in stimulating and promoting and supporting some public policy. For example, in 2004, the government of Puerto Rico established the creation of the Puerto Rico Cancer Control, the Comprehensive Cancer Control Center. In 2009, there was a law where it was established that the Department of Health, in collaboration with the Cancer Center, will be responsible for developing public policy. And we have been very active through the coalition in stimulating this process. There have been several laws that have been passed over the last years that support our work and make our work a little bit easier. These are just some examples of these laws. And just to finish, I'm just going to show you some material of a campaign that we are developing right now, a media campaign, in order to increase HPV vaccination and increase knowledge about HPV and vaccine, focused primarily on parents and adolescents. We have a website that is going to be providing information to the population about HPV and the conditions related to HPV. We have posters for or focus on adolescents and parents that will be making parents and kids aware about the vaccine, but also making emphasis on the importance of the 3 doses, because that's what the problems that we have. We have a lower proportion of women, kids, receiving the first doses, but our numbers in terms of the 3rd dose are below the expected, and we want to increase that. Also, we will have advertisement in newspapers, in Zoom media, in bathrooms and stuff that will provide different outlets for this campaign. Also, there will be advertisements on magazines, billboards, etc., so that our goal is to be able to increase vaccination over the next 5 years to the national levels at the US or better. Also, we have been developing educational materials through the coalition to be able to bring that message to the population, again, oriented to parents and kids, providing information about what is HPV. For adolescents, we prepared this bookmark with 2-faced bookmark that provides this information. And we have information that is a moving target where we provide to providers and parents places where you can obtain the vaccine in Puerto Rico for kids under 18 and for young adults. We have been trying to stimulate and create an activity for nutrition and physical activity. Again, the program for breast and cervical cancer that supports our educational efforts for population, for providers, and provides access to care to those women in need. And this is just some educational brochures related to those programs, the breast and cervical cancer. And this is the product from the cancer registry activities, the production of a report, the annual report on cancer based on the availability of new data. So this is more or less an idea of what we are trying to implement, what we are trying to do at the local level in order to move the cancer prevention and control agenda.